Thank you. That was a great presentation. Our next speaker is Pamela Schwartz. She is Senior Director of Community Health Impact and Learning at Kaiser Permanente. Schwartz.
Good afternoon. It's really nice to be here again. I haven't been here in a while, but I see a great mix of some familiar faces and a lot of new faces, so super exciting. And when Jim did the physical activity break this morning, I had a flashback so to my earlier days here. So I am here to tell you about Kaiser Permanente's Community Health Initiative. Sorry. The Community Health Initiative has been around for a long time. We started designing in 2003. We're now in over 60 communities across the nation, touching over 700,000 residents, 200,000 school-age kids, and growing. And it's a multi-sectoral, community-based obesity prevention intervention targeting a single geography. So not a single race or ethnicity, but a single geography. And at the time when we designed it back in 2003 and started implementing in 2004, the evidence was super sparse. We didn't know what worked, and we certainly didn't know what worked in which populations. So our equity lens back then was to pick the most vulnerable communities and then to engage community in the design, in the implementation, and in the evaluation. And early on, and like many people who came along with us for this 10-year journey, we started to see transformations in our community and physical environments. The physical communities were changing. Bike lanes, sidewalks, parks, playgrounds, cafeteria conversions, lots of similar things going across the nation. But for us, one thing we realized is that we really needed to focus on not just were things changing, but what was the nature of those changes? Were they strong enough to move population health? Because that was our charge. We're a healthcare organization, and we were charged with improving population health. And we were trying to do it through a community-driven way, and there were tensions with that at times, and I'll talk about that in a few minutes. But in the bottom right is probably our biggest contribution to the field. It's this thing we call DOSE, and it's this idea that if you want to move population health, you have to touch a lot of lives, and you have to touch them in a way that makes a difference. So you have to have a really strong touch, which might mean multiple times, multiple days, multiple interventions, targeting the same population. So here's what that looks like. This is an example in a school setting, because this is where we saw the majority of our impacts. So let's take the top, a school setting, healthy eating. So we have conversations with our community partners that go something like this. They want to start with a vending machine. So how about putting some healthy food in a vending machine? How about putting all healthy food in a vending machine? How about a vending machine ban? How about taking on the food environment in a school? So things like cafeteria conversions, competitive food, rewards in classrooms, before and after school fundraisers, really changing the food environment in the school. And then how about considering where kids are going on the way to or from school? So corner stores, mobile vendors, things that are touching kids where they can get unhealthy food. If they're not getting it in their school, but they're bringing it to school, how do we move out into the community setting? Active living. Lots of schools wanted to focus on safe routes to school. Oftentimes it started as one event, maybe Safe Routes to School Day. So how do you do that? More days, more kids, district-wide, year-round, before school, after school, longer distances. How do you keep asking the question, can we reach more people more times with more intervention? Can we make the streets more walkable? How do you put in sidewalks or crosswalks? And this doesn't have to be in this order. In some cases in California, it was actually easier to put in a sidewalk than it was to do some of the other things that we were trying to do, just because of the time. And then how do you do PE? So you've done the safe routes to and from school. How do you start looking inside the school? Again, doesn't have to be in this order, but it was easier for us to build a sidewalk sometimes than to get good PE in the schools. So really about having the right conversations to build the most impactful interventions. We had a community-driven approach, and I think this was mentioned in the panel before lunch. Just because we were focused on population health on obesity prevention at the population level didn't mean that was the most pressing issues for our community partners. Sometimes in order to get to, let's say, safe physical activity, you had to consider violence or economic security. We were doing this intervention through the recession, and so there was a lot going on. There still always is a lot going on, but in particular at that time. So we really had to struggle with, how much is this obesity? And we're charged with population health improvement, but we say we're community driven. What does that mean? We also changed our evaluation methods together in partnership with community early on, maybe 3 years into our 10-year intervention. We were told by our community partners that we were missing some things, that our evaluation wasn't telling the story of the impacts they were having in our community. So we changed it up a bit. We added things like photo voice. We had the traditional photo voice where you use it to identify needs and advocate, but we added a new version, new methodology for photo voice where we gave people cameras at the end and said, okay, take pictures of the changes you made in your community. And in your caption, tell us what's changed, why it matters, and what still needs to happen to create a healthy community. So really using it as an evaluation tool and also an advocacy tool for future changes. We also started measuring more proximal, so not just the population health improvements, but a look at we asked community, what do you think is going to be most impactful? And we set up little mini evaluations, not always the most rigorous, but some sort of look at impact of the things that mattered the most to communities. So here's a look at that. This is one example, Safe Routes to School. We had Safe Routes to School in, probably somewhere around 30 of our communities, but they look different across programs. So this is an example in Colorado where they had 12 schools doing Safe Routes to School within this one community, and a variety of different interventions, but sidewalks, walking school buses, promotion, and they were able to see a 7% increase. And the important thing here is that we went back 3 years later, and it looked like it was going to stick. So 3 years post-intervention, we had some sustainability. This is another example. This is in California, Bayview. This was they wanted us to look at what was going on in the congregation around the food system. So this was a look at, we surveyed pre and post of the members of the congregation, and we saw decreases in fried food, decreases in soda, increases in fruits and vegetables. So again, community said, this is what matters. Your population health, community level surveys are missing this. This is what we care about. Okay, so now rising up a bit, this is where we started to look at our population health improvements. Where we saw the most of those improvements was in schools and mostly in physical activity. So this is one example, and this is actually showing two communities in California, Santa Rosa and Modesto, but you can see this in many of our communities, some story like this, and it's where you had that concept of dose. So if you look at the strategies and the intervention, you see a combination of policy, systems, and environmental changes. So you see before school, after school, PE, promotion, education. What you're seeing is all those working together, single outcome, physical activity, single population, kids in school, captive audience. And we're seeing increases in aerobic capacity in this case, but we also measured kids' behavior change in other communities. And this was a consistent pattern where we had a strong intervention, combination of strategies, we were more likely to see population health improvement. Here's an example on the nutrition side. Similar concept. We didn't see as much nutrition improvements, and if you ask questions later, I can talk about why I think that is. But again, the pattern was policy, systems, and environmental change, which is what this initiative was about. If you saturate a school with that, we were able to see population health improvements, in this case in behavior change. Okay, so we had the benefit of seeing 60 communities, so this is a look across all of them at some of the findings that we saw. In a nutshell, after 10 years of intervention, we learned these things. Community matters. You have to pay attention to how you do it, how you engage community. We didn't always do that the right way that we wanted to do that. And what we learned is that when you're building capacity, you have to think about capacity for what? So not just building capacity for capacity, but building capacity towards something, towards advocacy, towards something that is going to be connected to the rest of your intervention. I already said this, but we learned that schools were a promising setting. Our most promising setting, community, was much harder. Happy to talk about that later too if you have some questions. But large denominator is the short answer. It was just hard to see population health improvement. And the most promising strategies were in physical activity. Individual strategies were in physical activity, especially if there was a combination, like I showed you earlier, of physical activity strategies. In communities, we saw programmatic changes, but not population health improvement. And on the bottom left, we were able to look at a lot of communities and a lot of strategies. We probably had something like 20 common strategies across the 60 communities. And so we were able to look at when things worked more than others, when strategies worked more than others. And some of the mixed results showed up in things that communities really like to do. And so we had to grapple with what does that mean for us. We had mixed results in corner stores, school gardens, and also isolated health promotion. When we mixed some of those together with other things, it was much more promising. But individually, we had to have conversations with ourselves and with our communities about, are those interventions that are going to make a difference, especially if our end game is population health improvement. We also learned in that green box something very obvious, which is that this stuff takes time, and so our longer interventions had more impact. And we had variations of anywhere between 3 years to 10 years of how long we invested in different communities for different reasons. So the longer communities had more impact. That's kind of a no-brainer, but we weren't always following what we knew. And then the bottom right is this thing that I already mentioned, this dose matters, is that it's a combination of strategies aimed at a single population, all coordinated and targeting people throughout their day. Okay, so now I'm going to switch gears a little more to say, so that was our community health initiative. We've wrapped it up about a year ago. We have some communities that are still wrapping up individually, but we've turned our attention to a bigger, more ambitious community health strategy that still has equity in the center. So I'm going to talk a little bit about some of the tensions with that as it might apply to this group. So we now have sort of an all hands on deck, more comprehensive. The idea is scale and impact. And scale and impact and equity, there can be some tension there. So we're still trying to figure out what that means and how we can best deliver all of that together. And when do you have to make choices? With a community health with the community health strategy elevated, we have a new and ambitious and hopefully rigorous community health measurement strategy. And at the end of the day, we're taking a look in our footprint at how healthy are our communities and what is our contribution towards improving the health of our communities. And so within that, we have an equity index. And so that's what I wanted to talk to you about. Fortunately, our equity index shares your definition that you presented this morning, thanks to the Robert Wood Johnson Foundation. So we have the same definition of equity that Shariki presented. We have upstream indicators in our index, like we've been talking about today at the bottom, things like income, education, employment, housing, all the things that have been talked about today are in an index. And then we look at it in two different ways. One is we take an average of each of our individual geographies. So we're looking at this by service area, by region, and across the nation. We look at the average and compare it to the nation. So like the county health rankings does to the 3,000 counties across the nation, we're comparing our footprint to that. Taking those indicators, creating an index, and comparing it, the average to the nation. And then we're also looking at the variance, so the disparities. So what you see in the top right that's Alameda County, where we're headquartered. And that is just a look first at the county, which shows you that Alameda County is doing pretty well, blue, mostly blue is good, when you compare it to the nation. But when you look at the variance, which is the red, that's when you start to see where it might make more sense to intervene in different ways. So it helps to give us a sense of how we're comparing and then where we should target our resources. So this is brand new, kind of hot off the press, but we're starting to populate it with real data and take a look at the implications of how this tells us better ways to organize our assets. We also have been working on equity in some other ways in our grant-making strategy. So how do you apply an equity lens when you select grantees and also work with grantees moving forward? And then also in our community health needs assessment, this was mentioned I think earlier this morning, that as part of the Affordable Care Act, all nonprofit hospitals have to conduct a community health needs assessment and then create a plan that addresses those identified health needs. For us, obesity is an identified health need in almost all of our hospitals, and it has been for all three CHNA cycles since the Affordable Care Act. It's every 3 years. But what's different this year, actually, around obesity is food insecurity is showing up in ways that it hasn't before. So we're trying to figure out what that means for us. Like, what does that mean for our intervention, and how can community help us to design that? And so we have community voice in our CHNA process of interpreting and understanding data, and hopefully in creating solutions. And the creating solutions part, as was talked about in the panel before lunch, is something we have to take more seriously. What is the best way and a better way to use community voice in our strategy, in how we develop our strategy? And last, together, actually, with many of you in the room, we've been working towards publishing. We have probably just towards building the field, because when we started, it was very nascent. And so really trying to take what we learn and feed it back so that others don't make the same mistakes that we have and can learn from what works. And so we started together with the California Endowment on the left in the early days and published the very beginnings of what we had learned together. We were some of the first two groups out of the gate with this place-based effort. And then we, to the right, we locked ourselves in the room. Bill, I think you were part of this. We locked ourselves in the room, funders, evaluators that had been doing this work for, I think it was at that point, maybe 5 years or 8 years or something, and said, okay, we all haven't, there's other, I think Deb was there too, maybe. We hadn't published yet on findings. So while we can't wait for that, what do we know about what's working, and how do we help tell the field that? So we created a white paper that said, okay, here's what we think works, and in what ways does it work? And then there's a Dose Matters produced by this Academy, and then a more recent publication on the far right, which came out last year, which was all of our findings from our Community Health Initiative, 13 articles in that American Journal of Public Health. So that's our most recent. And all this is really just to say, thanks for being at the party with us. A lot of you were there, and we've learned a lot, and there's so much more to learn. When I was listening this morning to the breakdown of race and ethnicity conversations, gosh, if I'd only known that, I think our intervention would have been different. And now that we know those kinds of things, what does that mean for us in planning for the future?
Thank you.